Thanks, Gareth. So Patrick, who's working with us on the trial from the Health Economics Department in Birmingham University, is going to tell us about what we're doing in the trial to look at value, as Matt described it.
Okay, my name is Patrick Moore. Unfortunately, I know nothing about the sky at night or stars, but I have been working on a number of clinical trials. My own interest in health economics focuses around healthcare utilisation and pharmacoeconomics. And today I'm just going to talk a little bit about what we're doing in the health economics on the BASIL trials. I'm pretty sure most of you will be quite familiar with a lot of the things I'm going to talk about, and you may have seen them used in other similar trials. So key issue for decision makers within the NHS is resource scarcity and trying to decide what interventions that they're going to fund and making those tough choices. And health economic evaluation is one of those tools that they're using to try and make those decisions. So basically, what we're using here is cost-effectiveness analysis, and it's appraising competing strategies in terms of the costs and the consequences. The consequences here being the health outcomes. So we're comparing our two interventions to try and figure out which one is the most cost-effective. So identifying or determining the most cost-effective revascularization strategy will enable the NHS to ensure that they're using the public resources in the best possible way for their patients. So the economic analysis plan has two components. First of all, there's a within trial analysis, and then there's a model-based analysis. So the within trial is we're measuring all the costs and the outcomes that happen during the study period. The model-based analysis is then using that data along with some other data and some probabilities to extrapolate beyond the trial to look at the whole lifetime horizon of the people with this condition. We're using the NHS perspective as recommended by NICE, but we're also doing some initial analysis. We're collecting some additional data to look at the wider societal perspective. So in terms of the within study, we are collecting that data alongside the trial, and we're looking at the resource use, for any primary or secondary interventions, any hospital stays, any primary care visits, but we're also collecting some private resource use. So people going to private appointments or care, their out-of-pocket expenses, any time lost from work or leisure activities. We're also collecting the preference-based quality of life, so we're collecting this at baseline and at a number of different points throughout the trial. We're using three different measures, the EQ5D, the SF12, and the ICE-CAP-O. So the first two are just generic quality of life measures. I'm going to talk a little bit about one of them in a moment. And the last one, the ICE-CAP, was developed in the University of Birmingham and focuses particularly on older people. So collecting quality of life, how exactly do we do it? So this is just to kind of give you an example of, and it applies to all the other generic forms. So this one is the EQ5D. We've got 5 different questions that we ask, so it's quite short and quick. There's mobility, self-care, usual activities, pain, and anxiety and depression. So within each area or domain, we just ask you to kind of rank it on 3 levels. And each level is given a score, so 1, 2, or 3. And at the very end, we get a 5-digit kind of health state. So that 5-digit health state has a quality of life attached to it. So we have a tariff which was developed from a national survey where we assigned a rate or a quality of life between 0 being the worst and 1 being the best to each of these states that we collect from the survey. And that quality of life then feeds into our quality adjusted life year. So Qualys, I'm sure you've all heard about Qualys. And these are a way of combining the quality of life with the length of time the person is in that state. So it's that bringing together of 2 things, the quality and the length of time that the person is in that state. So we use the score that we got, that tariff score that we took from the EQ5D, and we multiply that by the time or the length of time that somebody is in that condition, and that gives us the quality adjusted life year. So there was something else I wanted to say about Qualys. Okay, I'll keep going. It'll come back to me. So the Qualys then feed into our incremental cost effectiveness ratio, or ICER. And this really is just looking at a difference in the cost between our two interventions per quali. Okay, so that it's a comparison between our two treatments in terms of the costs and the outcomes. And the intervention may cost more than the current practice, or the treatment B may cost more than treatment B. Treatment B may cost more than treatment A. It depends on if the NHS may be willing to pay more if there's a better outcome. So it's not particularly about the cheapest outcome, but it is about getting the best cost per additional quali. So the other part of the study, looking at the model-based analysis, this is where we're trying to identify the costs and benefits over the entire lifetime horizon. So this moves taking the data that we've gathered within the trial and then trying to model what will happen to these people over their entire lifetime. So like I said, we're taking that patient-level data from BASIL on the costs and the outcomes, and then we're trying to extend that beyond the endpoint of the study. We're using things like the probability of the patient requiring limb amputation, any resource use that might come in for post-treatment, and extrapolating our quality of life post-treatment and after any amputation down the line. We also will be doing a value of information analysis. So we'll be looking at the certainty we have around our model and what we can do to change different aspects of that model to ensure that we're making a good recommendation. So in terms of the health economic evaluation, there's two main outcomes: that cost per additional quality adjusted life year, and also there's a cost per year of amputation-free survival. So the amputation-free survival is very particular to this area, whereas our quali, we could compare our qualis here with other medical interventions. So the interpretation of the results will be with a view to informing policy and making some further research recommendations. And I think that's it in terms of economic analysis. Thanks very much.